is still the host of that other Zoom link. So, you can hear me? Okay, great. The only thing will be just a quick note is that this is my Zoom and I didn't know we were going to be using my account for today. So I haven't been able to upgrade it yet. So it might kick us off in 30 or 45 minutes. If so, I will resend you the link. Okay. I need to upgrade so I don't have the free version. All right. Is everybody here? Let me see. All right.
Currently working in the department of emergency medicine in the hospital. It's been a pleasure meeting of you.
All right.
Hello everyone, I'm Dr. Thư. Now I'm working in the emergency department of the International Hospital. It's every hospital. It's not District 7, Dr. Đại.
Awesome. Well, thanks everybody for being here. Sorry about that little delay. Yeah, let's get started. And then Dai, or if you guys feel free to interrupt me, or if you use the chat, someone just let me know if I can't see the chat, if anyone's asking questions or saying anything. All right. I will share my screen. Here, give me a sec. I would need to. I'm just gonna get back to the top. And let's see. All right. You guys see everything? You can hear me okay? Yep. All right. Great. I'm Ranjita. I'm one of the ER doctors working at UCSF Fresno. Today we're going to talk about chest pain. An extra shout out to Ryan Ernst, who had made the slides for the first part of this talk.
Recording
he
in
was
progress.
Originally going to give it. So he gets props for this animated heart that's on this page. So, all right. So basically, when we think about emergency medicine, we would like to think that we would start with something and then always we're going to be able to do something else. So chest pain is kind of similar to this.
Yes, sir.
In that we do have basically an algorithm that you can follow. Let's see, somebody. Okay, you guys can all hear. It's like the heart score. I'm sure a lot of you guys have heard of the heart score. This is something that we can use to risk stratify chest pain patients. However, using just this it's kind of simplifying something that's not that simple, right? When you think of like chest pain, you have all of these different things that will lead us towards one thing versus another. And it's pretty hard for that to be really just all put into the idea of the heart score or other risk stratifying scores. They can be helpful, but it's not going to be able to give you all the information. Like if you look at the heart score, they do talk about some history things and some risk factors and the troponin, but they don't really cover everything that we need to take into account when we are talking about chest pain. So the thing that we talked about last week is kind of what we want to stress continuing through these lecture series, which is that we don't want to focus exactly on what to think, but how to think. Last week, Dr. Krager gave us a great talk about how we think like an emergency medicine physician. Clearly, all of you are working in the ER and seeing patients all the time. So you know a lot about what to think. So these lecture series are going to be more about the nuances of how we should be approaching our chest pain patients and creating our differential. And that's more fun. So the best way to do this is really to create a mental model. So chest pain, I'm going to kind of skip through all of these things here, but really it's just the idea that we want to have a mental model to look at chest pain. It's not going to be a linear thing where you're saying, okay, you have chest pain, you always order this set of labs and always do this exact thing. But we still want to have some sort of idea of what we're doing when we have chest pain. So there's a lot of things that go into it. So lectures help, papers, using guidelines, risk tolerance. Is this a patient that you feel comfortable going home or not? Do they have follow-up? Your clinical experience and things that happen within the institution that might lead you one way or another with something like chest pain. Now, look at all these animations that Ryan has in his talk. So anyway, when you think of chest pain, there's all of these different diagnoses that you can have for chest pain. But when you look at it like this, it's really overwhelming and it's really hard for us to consider everything for your patient, especially when you're a busy emergency doctor and you have a lot of other patients to see. So it's much easier to think about what is dangerous versus what's not. So here we have all of these dangerous, can't miss diagnoses for chest pain. Unfortunately, a lot of the time, it's basically nothing. It's a lot of time we're going to have chest pain patients. I'm sure each of you and myself included today have discharged chest pain patients who we never figured out what was going on. But what we did do is decide that these most dangerous things are not happening. And a lot of times it's the best way to look at that way with the ER because we don't always diagnose what's going on. We can tell you that what's not going on. So when you're thinking about chest pain, the H&P is obviously very important. Things that we want to think about with our patients, one, is there a cardiologist that they have? Do they have any interventions that are going on right now or in the past? Did they have a stress test or an echo, which is ultrasound of the heart, recently? And what meds are they going on? Are they on right now as well? Some of this is things that we would have asked anyways, but some of this is very chest pain specific. In terms of the physical exam, of course, you want to check your pulses. You want to still do a good neuro exam. It depends how extensive you need to go into that if you're actually worried about a neuro component. Sometimes the dizziness patients can be very confusing about whether there's a chest pain and dizziness versus a neuro versus a cardiac etiology. Look at their legs. Do they have pitting edema? Do they have scars or a sign of having a pacemaker? And an ambulatory oxygen, we don't always do it on every patient, but this is something to keep in mind that can be really important in certain patients that you're concerned about. And of course, there are certain things that your mental model needs to go to, which is that if you have an EKG, a trope, or a chest x-ray, and this is a patient that has been here before, then you definitely want to compare it to what they've had in the past. And if there's something odd, you can always take another EKG or trope or chest x-ray to see how it's progressed. Also, just a plug for ultrasound. I know you guys have, I don't know if everyone has an ultrasound in their department. I know we had been to a couple of the departments and they did have an ultrasound, but it can be so useful in our dangerous etiologies, especially ACS. In dissection, you could use it as well. PE is great for looking at right heart strain, cardiac tamponade, of course, with a pericardial effusion, and then attention pneumothorax, which is even better than a chest x-ray in the right hands. A pneumonia and esophageal rupture, they're usable too. I'm not sure an esophageal rupture that I've used ultrasound actually, but it still could be really helpful if you do have it. And I'm sure if we want to go into more ultrasound education, we can do some of that in a later lecture. So risk stratification is something that's kind of difficult to do. That's why we use things like the heart score or other types of things to help us with the risk stratification, but it can never actually totally be zero, right? There's always kind of along this realm of 0 to 100. And even, and we're going to have some miss rates. That's just part of it. Ideally, we want to have less than 2% miss rate. And all of these heart scores and the PERC score, the PCARN score, all of them still have a bit of a miss rate as well. So they're not foolproof. So you should always follow your gestalt and really take into account some of the other things that we've talked about besides just solely looking at a heart score or PERC or PCARN. And and also it's also very important to realize that anyone can have a heart attack, right? Anyone can present with one of these dangerous things. Usually you're thinking it's going to be someone who has lots of risk factors, but we see all the time that someone who is very active, who has no risk factors, suddenly has a heart attack. The New York Marathon happened yesterday, and I think there always is, every time there's a marathon, there's usually somebody who potentially has a cardiac arrest, and those are usually obviously very fit people. So you always need to keep your differential at the top of your mind and consider all of the dangerous things, even if they're not likely. It doesn't mean you have to necessarily test for every dangerous thing, but if you do not ever even consider them, then you're not going to diagnose it when something, the zebra, well, the time that it would not be expected, it happens, right? So let's see. I'm going to skip through some of this so we can get to the cases. So that's kind of the idea when we're thinking about a mental model for chest pain, keeping in mind important things you want to ask on their history that are specific to chest pain, like their cardiologist, do they have a pacemaker, when their last stress and echo is, looking for things specifically on their physical exam, their pitting edema, their O2 sat, things of that nature, making sure that you get an EKG, a trope, a chest x-ray, and always remembering to check that versus a prior. Or if it looks odd, you can always order another so you can check it versus the next. And now and then knowing your dangerous diagnoses and understanding how you are going to decide if someone is high risk for them or not, and what tools will help you decide whether we need to do further testing. So we're going to go through each of these and just talk about them as well. All right. So For ACS, before we start, before each of them, the best way to think about this is to have, well, the way we're going to go through it today is we're going to have the definition, the risks, the signs, the symptoms, risk stratification tools that you can possibly decide to use, what the definitive test is, and then there was a whole section on literature and current issues in the original version of this lecture, but I think it's a lot to go into today because we want to also just go through the cases. But always it's good to know what the current literature is and know where you should look up to find out more about that thing, right? So for ACS, we tend to think of it as whether there's a STEMI, an ST elevation myocardial infarction, an NSTEMI, a non-ST elevation MI, or an unstable angina, which is basically where you're having, pain on exertion and you haven't actually had total injury to the heart, but there is some injury when you do activity, right? We all know this. The thing is that we are somewhat going towards, at least here in the US, the idea of an occlusion myocardial infarction instead of a ST elevation, a STEMI versus non-STEMI. I don't know if that has been something that you guys have been talking about in Vietnam or not, but we can always go into it a little bit more if you'd like. But the idea behind this is that there's so many other versions or things on EKG that are the equivalent of having a total blockage of your one of the vessels in your heart that aren't necessarily an ST elevation. We're not going to go into every single one of those things today because this is more of an overview of thinking about how we go through the chest pain approach. But that would be something that is good to know because it is not just your ST elevations that we need to be concerned about our patients having occlusion. So at least here, there's this idea of the OMI that's coming into our nomenclature. Now, I think we all know that certain signs that are more likely and less likely, but thinking about that will help us figure out where on our differential these dangerous things are. So for ACS, if the patient has diaphoresis, so they're sweating a lot, they look really terrible, they have radiating pain, they have nausea and vomiting, or they have pain when they're exerting themselves. We know these are all things that are not very good. Whereas if the pain is something that is positional or stabbing or reproducible, that makes us feel a little bit more reassured that it may not be a cardiac etiology. And as we talked about, a lot of times we do use strict risk stratification scoring. For ACS, I think heart score is probably the most commonly used, but TIMI score, GRACE score, those are sometimes used as well. But it's always important to use those in combination with your physical and history and everything else, your gestalt as well. Which, sorry, the word gestalt is like, one of those, just to explain that's basically what you think as a clinician just by seeing so many patients and understanding whether a patient is sick or not sick. And what's nice is that for at least the way we look at things right now, right, a STEMI and an NSTEMI and an unstable angina, there's a good way we can tell these things, right? STEMI, we can tell off an EKG, and NSTEMI, we can tell from getting the troponins. And unstable angina, well, that is something where we have to really get off our history and physical, and there isn't a clear thing, a definitive test for it, right? But the rest do. Now, for aortic dissection, generally we can have ones that are they can be smaller or larger. It's kind of a really hard thing to diagnose. It's one of those things that has so many different presentations that if you don't think about it, you can miss aortic dissection on a patient that's not doesn't present as normally as they do in the textbooks. There are two types. There's the type A and type B. I don't know how much you necessarily need to know, but the type A tends to be near the top. That tends to be more surgically managed usually, and type B tends to be more medically managed. But that's not always true. So it's still, you need to talk to your surgeons in your department. And for this one too, things that would make us think that aortic dissection is higher on our diagnosis list would be things like if they have tearing, ripping pain, if they have migrating pain, if they have neurodeficits, right? The chest pain plus some a weird like neuro findings, that might be something where you could be thinking about this instead, as opposed to if someone not having chest pain and has no tearing or ripping pain or a normal chest x-ray. I had a patient a year or two ago who had come in as a stroke rule out because she was not didn't have strength and she wasn't moving her leg on one side, but she was also hypotensive and she was having chest pain. And so, there was all this momentum for her to get a rule out stroke, but we were able to stop all of them in time to make sure she got her angio through her entire chest, abdomen, pelvis, and she had a large dissection. So it's really important to keep these things and remember that, neuro deficits plus something like a pulse deficit or a chest pain, things like that, we could be thinking about aortic dissection. Is not always going to be something like a stroke or something neuro. And as I just said, definitive test would be a CT angiogram of your chest, abdomen, pelvis to look at that whole aorta. So for PE, we all know this is a blood clot, but there is different levels of how bad blood clot can be, right? So if you have a massive PE, that's somebody who is hemodynamically not stable. They are very sick. Their blood pressures are probably low. They're tachycardic. They're one of your sickest patients. You can get a submassive PE where you might see some pressures and RV strain, especially if you're using your ultrasound. You might see some of that RV strain there, maybe even have a troponin as well. And these things can help you, right? Trope, BNP, like I said, your ultrasound, your EKG. We know I had learned about certain EKG findings being pretty specific with pulmonary embolus, but what we found is that a lot of times, like I don't know if you guys learned about the S1, T3, the Q3. I don't know if you guys learned about that, but a lot of times these EKG findings are not. They're very subtle, and you can't rely on them for a PE. I wonder, did we talk about it here? Yeah. So here, things like when we think about PE, you think about having dyspnea, chest pain, having tachycardia, and having decreased O2. But what is really interesting is that you can definitely have a normal O2, or you could be not tachycardic, or you could not have chest pain in these patients. So shortness of breath tends to be the thing that most people have, but you can't always be reassured with a normal oxygen. So once again, taking into account some of the symptoms and the history and physical findings that make you think it's a PE, and not being reassured by one value specifically. which is basically what the gestalt is, right? What you think that is going on is probably most important. The Wells and Perk rules are also ones that are good to use for PE, but you want to use it in combination with everything else. And like we said, we're going to be having a whole other lecture that's going to be just on risk stratification. So we're not going to go into each of these rules like right this minute, but if you had any specific question, we can go through it. Oh yeah, Geneva years, so there's more of them. And we know it's a CT angio would be of the chest is what we're going to be looking for a pulmonary embolus. A VQ scan, do they do VQ scans often in Vietnam? I know. We don't do them often here. You can use a VQ scan for a PE. Sometimes they use it in pregnant patients, or for some reason someone can't have a CT. But generally, I don't like to use them much because even if the VQ is positive, all it means is that you have to get a CT then. And a lot of times what they use in the VQ scan is going to give you as much or maybe more radiation as a CT. So I tend to go and use the CT angio and not really use a VQ scan. But it is something that can be used for a PE. And yeah, the PESI scores was one of the risk stratification tools you can also use for trying to figure out how severe the PE is once you've diagnosed it. Cardiac tamponade, this has two components, right? So the idea of having a cardiac effusion, it doesn't necessarily mean it's a tamponade. You can have fluid around your heart that has built up slowly over time and is not causing immediate problems for the patient. And then tamponade is when it is an immediate threat and something needs to be done right away. A lot of times, this is when we think about tamponade, ultrasound comes in handy a lot here because that's where you can tell whether you're getting some atrial collapse or ventricular collapse. And those are signs that this is an impending sick patient who might need something like a pericardiocentesis, as opposed to having a small effusion that has been there for a long time and is not necessarily something we need to take care of in the emergency department right away. Classically, the signs and symptoms we think of for cardiac tamponade is if you have your bounding pulses, your JVD. They talk about having an S3 gallop on your exam. I personally have never heard an S3 gallop. I don't think that's something very easy to really hear. And then people talk about that Beck's triad and having some Kussmaul sign. These are all things they talk about. It's hard to find all of these things on a patient with one of these things, though. The classic EKG finding here is for the alterons on the EKG. I think they're gonna, yeah, no, we have 10 minutes before they kick us off the link right here. The large cardiac silhouette can definitely help you on chest X-ray, though, because that if you're not expecting that, that might be a good time then to get your ultrasound and see whether there is a effusion around the heart. And I've caught at least one or two that way myself. And as we said, this is really one where ultrasound is so easy because it'll give you your answer pretty much immediately if you just put that probe on the chest. Tension pneumothorax. This is where it's obviously compromising your actual function. You can have a pneumothorax clearly that is not doing so, where you're not having that tracheal deviation or having a severe shortness of breath. But this is the one that's emergent. Using ultrasound for this is really great. Chest x-ray, it's especially if they're supine, it's kind of difficult to catch a smaller pneumothorax. Ultrasound, if in the right hands, especially if you see a lung point, is extremely good at catching that pneumothorax. So I think of all the things, your heart and lung exam is one of those easiest things to use with ultrasound and can give you a lot of information very quickly, especially if you're seeing if you need to put a needle or a chest tube in the chest. I'm not going to go through all of that because we don't have too much time, and I want to make sure that we get to the cases. Pneumonia. So this is pretty straightforward. I'm sure we all see a bunch of pneumonia patients every day. Chest pain, dyspnea, cough, fever. These are the general things we're going to see with our pneumonia. Of course, people who are older or immunocompromised, they may be having subtler signs and just present with altered mental status, just with tachycardia, maybe just not feeling well, and maybe not mounting that fever that we would like to see, that we usually would think of to see with pneumonia. This too, you can learn how to use ultrasound to look for pneumonia, and it is extremely sensitive if you are able to use it. And of course, CT is very good. So a lot of times I think we do find that once the X-ray is equivocal, that we are going to be going to CT. And you can use things like your pneumonia severity index or CURB 65. I think that one's a very commonly used to help with our pneumonia patients. And lastly, esophageal rupture, which is a full thickness tear of the esophagus. This is not very common, but if it does happen, it's something you definitely want to catch. A lot of times they're going to have chest pain, but they don't always have your fever, dyspnea, and your nausea, vomiting. A lot of times, though, the nausea, vomiting does lead to this esophageal rupture, but it can be other things that cause it. People also talk about hearing this like Hammond's crunch and then having sub-Q emphysema, but sub-Q emphysema actually takes a while for it to really show up, or you can feel the crackles. You may not actually feel it right away when this happens. Sometimes it takes a bit of time. And if you see pneumomediastinum on chest X-ray, that is a sign for you to think about this, along with especially left pleural effusion. You can also get a CT with contrast that's going to be better, and then a CT esophagram, although that's not very common for us to get in the ER. Of course, it's good to remember about what your patient looks like, because you can have a patient that has a little bit of pneumomediastinum, and that does not necessarily mean that they have an esophageal rupture. So if they look sick, that might be something you want to go down. But if they did not look sick, you can sometimes have just a little bit and it not be a full esophageal rupture. And these are just some of the places that we had used to look at some of that stuff. We talked about, I think you guys have the Corpendium website, which is great because it's pretty comprehensive. So especially to talk a bit more about any one of these things, if you haven't already, definitely go through and look, because they mention a lot of the risk stratification tools, and they have procedure videos and everything that are all linked into Corpendium as well. So the take homes for this lecture part of it is that we should practice to create those mental models and think about what you need to know and find out from your patient in order to figure out what kind of chest pain this is. And risk stratification tools is just going to be part of that thought process. It's not going to be the end all be all. We went through all 7 deadly causes of chest pain, which are important for us to exclude in our patients, or find it. And then using ultrasound can definitely help you, especially with a lot of the lung pathologies or heart pathologies. They can give you really quick data points that are pretty accurate. I know I went through that kind of fast, and of course it was, Ryan, initially I was going to give that lecture, but do you guys have questions on the lecture part? I probably should stop for a few times during it though, but let me know if there's anything in the chat. Okay. I'm about to lose my Zoom link in 3 minutes. So I think probably what makes sense is I will just send you guys a new link right now so we can get off and get back on in order to continue. Okay. Does that sound okay, everyone? I'm going to send it out again. And then we'll do the case. All right, cool. Okay. Shoot. Thanks for getting back on, guys. I know we're almost done, but I want to just do at least the one case that we should go through. And then, so I'm going to show that case thing again. All right. So, and we can just let people on as they go. So for the first, we'll probably just do this one case, but it would be great if you guys could participate when we ask a question for like the next steps, or you can even write it in the chat if you'd prefer. And then you can tell me if they write anything in the chat too. So for our case one, we have a 56-year-old male with dizziness. And these are his vital signs here at the bottom. So he's got a heart rate of 80. His blood pressure is 110/60. His respiratory rate is 14. He's satting 97% on room air, and his temperature is 37.3 Celsius. All right. So, and when you walk up to him, the first thing you always end up doing with a patient is just seeing what they look like. And this patient looks unwell. He's laying down on the cot. He looks fatigued. He's pale. He's diaphoretic.
Recording in progress.
The primary survey, he's talking normally. He doesn't have respiratory distress. And his circulation, he's a bit cool. He's clammy. He has pulses, but his cap refill is a little bit delayed at 3 seconds. So what would you guys want to do at this point? Now just hearing the vitals and what he looks like. Any thoughts about?
I think we just start with the ABC. I think that this patient AP is okay. Maybe C have a big problem. Just apply the monitor and repair the IV.
Yeah, perfect. Exactly. So somebody who does look sick, when we first saw his vital signs and his chief complaint, I would have probably thought, maybe nothing too worrisome, because his vitals all looked okay. But as soon as we got to see him, he's talking to so anyway, the patient looks sick. So exactly, you're right. This is somebody who we want to have on a monitored bed and have those IVs in, and we want to think about what we might need to get for him as well. And these things could be, do we need to give him some fluids? Do we need to get a blood glucose? Do we need an EKG fast enough? But yes, you're right. Monitors and IVs first, because otherwise we really can't do much else. So once we are doing all that, you finally come over and you get to talk to him. And this is basically what he is telling you, right? So he has hypertension and diabetes, that past medical history. He had dizziness that started this morning when he was walking. He almost lost consciousness and then he vomited. He also has some generalized weakness. He feels a bit short of breath and he's a bit lightheaded and has some epigastric pain. It's dull, he says, and it's aching. Also smokes. He takes medications, but he doesn't know what they are. And in terms of family history, has a brother with cardiac problems. And once you got him on the monitor, we did the ABCs, but now we can go back and do the full physical exam. And basically the rest of the physical exam is nothing too contributory. His lungs are clear. That would be something important that I'd want to look at. Abdomen is non-tender, non-distended. And then his extremities are normal. He doesn't have pitting edema. And a neuro exam, he was having dizziness. So this would be a patient where I would want to do a thorough neuro exam. And that also is pretty much non-contributory. And we didn't walk him because he was feeling really sick, but the rest of it was normal. So it'd be great if people could tell me now what you are thinking about diagnoses that you would be considering in a patient that presented with these symptoms. I know it sucks to have to participate in stuff, but I think it would be good. Some people can give some ideas. Or what's the thing that you think is the most dangerous thing we got to think about? And what do you guys think is the most likely?
Maybe PE.
Yeah, PE, definitely.
Digestion.
Which one did you say?
Digestion.
Mm-hmm.
Over.
Anything else?
I'm thinking of myocardial infarction as well as aortic dissection.
Yeah, definitely. He's having those would be dangerous things you don't want to think about. Agreed. Any other thoughts? Well, we got a lot of the good ones. So we talked about heart problems, and MI, right? Aortic dissection was mentioned, maybe aortic aneurysm. We talked about, I don't know if we talked about, did someone say the myocarditis? I mean, he could have congestive heart failure. He didn't have anything on his lungs or his legs, so probably less likely. Myocarditis, somewhat rare, but those people can be really sick when you have that infection of the myocardium. He did have that sort of epigastric pain, so it actually could be something like pancreatitis or GERD, but of course we don't necessarily want to make that our top thing, right? That's not the thing that we need to rule out. That would be almost like a diagnosis of exclusion. Could be, was it referred pain from his gallbladder? Is he actually having bleeding? He could be dizzy and actually having a GI bleed, but he, hadn't mentioned to us. So just things to think about. Or whether it's something else, like he just has an infection. I think someone might have said that as well. But you guys mentioned the ones that were really important. Oh, PE, which PE should be on here because definitely PE would be something that it could possibly be. So, yeah, I must have just, that's a good catch there. So what would you want to order? What's the most, what would be the things you want to see first?
So I will order the ECG in this patient, the complete blood count to accept the dizziness and the symptom that suggesting this patient may be having some blood loss since he has dizziness and tachycardia. So ECG and complete group count.
Yeah, definitely all pretty much right on. And what's nice is that some of the stuff you can get very quickly, and that could really guide us a bit towards where we're trying to go. I the labs, especially things like the trope and then the belly labs and the RBCs and the white blood cell count, the EKG, and then the chest X-ray as well. Those things would give us a lot of information, and things like the chest X-ray and the EKG are usually things that can come pretty fast, even though labs take a long time, and can rule out a lot of things. So what does anyone have any thoughts about this chest X-ray that comes first, I guess? All right, well, I'm not trying to trick you. This chest X-ray is not showing much anything too extraordinary on it. It looks pretty normal, but it's good to think about what we'd be thinking about, right? So, looking at it, do we see any issues with the airway area? Do we see any rib fractures or any other things on the bones? Are we seeing a pneumothorax on either side? Are we seeing any of that pneumomediastinum in the center? Or is the heart looking enlarged? Are we seeing, it looks like the margins of the lungs are all pretty sharp, and so there doesn't seem to be any fluid there. Something else, I would imagine that he would have a tender abdomen if he had like a ruptured diaphragm or anything, but on a chest X-ray you could look to see whether something like that was happening, which he doesn't here. So at least we have an idea of some of the things that it's not, and looks kind of not contributory. And then we have the EKG. Does anyone have any thoughts on this EKG? You guys can take a second to look at it. Assessing the EKG.
I can see some SD elevation in the inferior wall, so I'm thinking of inferior wall MR.
Yeah, so exactly, like, it probably looks a little bit subtle. I'm not even sure, it's less than one small box potentially in some of these places, but clearly with his story that's concerning and a physical exam that's concerning, you definitely can see these elevations in 2, 3, and AVF. It also looks like potentially those T waves look a little bit big compared to those QRS complexes, which is concerning. Usually you then look for depressions, which there's not clear large depressions, but V1, V2, V3, they all, they're not really depressed, but they look kind of, I guess, like saggy to me. And so, as well. So, yeah, I completely agree with you. I would be concerned about this EKG in this patient. However, if some of you guys did not see that right away and you were thinking it's a little bit on the fence and you're not sure, what's something easy that you can do to try and help you? I don't know if that question might be kind of hard to answer. You might be reading my mind. right, what I meant by that is if this is something that you're not so sure about and you're on the fence, you can always get a repeat EKG. And that can help you figure out whether this is something that is staying stable or if there's some dynamic changes that will make you more concerned. So if you were not worried about a STEMI or an MI before, you can get your EKG in 15 minutes later, and then it looks like this. So I guess I don't need to have anyone to really read it, but you can see here, like clearly those inferior leads look a lot higher than it did before. And it doesn't look the same as before, and you're seeing a bit of that AVL T wave inversion as well. So this case was picked out already beforehand, but I happened to have a patient that had an inferior STEMI yesterday. So these EKGs are actually, I just put in the ones for my patient that I had, and just like didn't catch which doctor had mentioned on the EKG, on the first EKG, but that first EKG I had in our hospital, we call a code STEMI. I had called a code STEMI on that first patient when I saw him in triage, and he went to the back, got this EKG in the back on before he'd gotten to the cath lab. And so, and they had taken him to the cath lab within 30 minutes and had gotten a 2 stents in the left circumflex area. So just happened to be, it was similar to a patient I had. So this is like his real EKGs. Let's see. All right. And as we talked about, basically, so that was the answer. It was the STEMI. But you're going to see usually those ST elevations. And if you're going to look for those depressions in V1 through V4, sometimes they can be really subtle, but that's why doing repeat EKGs can be really helpful. A lot of times with inferior STEMIs, you're going to have an RCA occlusion in addition or instead of the left circumflex. And if you can also have the whole posterior wall. So a lot of times you might want to consider getting a right-sided EKG as well to see if you have any other elevations showing more of the RV has been infarcted. And just a review of the management. I guess I should have just asked you guys that, but do you guys have any things that you think about for your inferior MIs, like the management that you would think once you know that this is a MI? Well, I guess I already showed it anyways. So
Yeah.
Yeah.
I'm sorry. Are you asking about the treatment of the inferior MI? The internet in my place is very weak, so I cannot hear properly.
Oh yeah, sorry. Yes, that's what I'm asking about. Yeah, treatment.
Yeah, I'm thinking in this case we have to maintain first is the oxygen level. We have to maintain it over 90%, as well as to second is about to ease the pain of patient. We have to first accept if this patient have right ventricular infection. If this person has right ventricular infection, we cannot use nitroglycerin, but instead we have to use all those pain for the medication for the pain, and then we have to use the aspirin, T2, Y, Ticagrelor or clopidogrel, and then starting.
It's like you read my my whole lecture already. So exactly. I mean, that's I'm sure we get a lot of these MI patients, but we want to check his oxygen level. We want to make sure he has IVs, make sure he's on a monitor. If you guys have the pads that you're able to place on him, I would do that for this patient, because these patients can get really sick, and they can get arrhythmias where he may need to be shocked out of it. So I would probably keep those all nearby. And then 100% you need to give the aspirin. And then the thing that is very different about the right-sided, the RV MIs, like these inferior MIs, is that you have to be very careful with nitrates, because you can definitely bottom out their blood pressure, as opposed to the other types of MIs. And if you can get them to the cath lab, that's great. But if you can't, then I mean, regardless, I would start a patient on the heparin as well, to make sure that they are starting to get some of that those medications. In addition, this patient, I mean, the patient I had too had normal vitals, and was not bradycardic, and was not hypotensive, because they ended up having a left circumflex occlusion. But when it is the right coronary artery, a lot of times that is what is supplying the sinus node, which is why if you've had patients that have had that kind of MI, a lot of times they're going to be bradycardic as well. So you might need to even pace them, or have to deal with that bradycardia, because they're not perfusing their sinus node. This is one of the patients too, where you can give them fluids if they're fluid down. As long as they're not fluid overloaded, fluids will help them with their cardiac output. With other types of MIs, a lot of times you may not want to give them much fluids, because they're not going to be able to pump if it's the left-sided. But with the RV MIs, these inferior MIs, as long as they don't have any other, contraindication, giving them some fluids can help them with their hypotension. And that's all I had on this case to talk about it. I think these sessions are supposed to be an hour, so I think we're already over, right, Di? So we're gonna be in 2 weeks. Next week we're going to be doing a lecture and having cases, but I'll try to make sure that the lecture is within 30 minutes so we can go through a couple more cases. And then in 3 weeks, we're going to be just going through cases. So that will be kind of nice, because then we'll get through more than one, because I know last time we only got through one as well. But I didn't want to keep you guys too late. Right, Di? It's only supposed to be till 7, right? I mean, sorry, the 1 hour, right? Yeah, okay. Yeah, all right. Did you guys have questions? Well, let me know about, and if you think of anything. I know one of my problems is also that I talk really fast. So if that's an issue, or if there's anything that is that you want to know more about, or like management or versus cases, or anything like that, I am doing the next couple lectures. So please let me know, or like let Di know if there's any feedback. And Di, you can just email me and let me know if there's anything that I can make more more interesting or more clear. If you want to do cases more, if I need to talk slower, you guys can always just put in the chat if that's true, because I know that I talk fast. Okay. Yeah. Yeah. Yeah.
Yes. Thank you, Ranjita. High yield lecture. Nice meeting everyone.
Yeah. All right. I'll see you guys next week. Bye.